This 3D model details the anatomy of the anterior neck. The thyroid gland sits centrally, characterized by its two lateral lobes connected by an isthmus. By rotating posteriorly, we expose a nodular extension called the Zuckerkandel tubercle. Surgeons and radiologists use this specific protrusion as a landmark to locate the recurrent laryngeal nerve, which runs just medial to it. During embryological development, the thyroid originates at the base of the tongue at the foramen cecum. It migrates downward along the thyroglossal duct to reach its final position. If segments of this duct fail to close, patients can develop thyroglossal duct cysts, which most commonly present infrahyoid, or just below the hyoid bone. The central challenge of thyroid radiology is prevalence. Thyroid nodules are ubiquitous in the general adult population. The vast majority of these are colloid nodules, entirely benign fluid-filled cysts that pose zero threat to the patient. Because nodules are so common, they trigger an immense volume of imaging. Ultrasound-guided fine needle aspiration of these benign masses represents a massive financial pipeline for medical centers, while frequently subjecting patients to unnecessary invasive biopsies. Diagnostic imaging of the thyroid therefore requires a strict triage algorithm. Radiologists must apply precise structural and functional filters to tune out the overwhelming biological noise and isolate the rare true malignancies. The first analytical filter is morphology, captured via ultrasound. Radiologists evaluate specific features, margins, composition, vascularity, and calcifications to assign a risk stratum to every identified nodule. This split-screen diagram isolates these morphological variables. On the left, we see the hallmarks of a benign mass. It features a complete hypoechoic halo, a dark, well-defined border surrounding the mass. Internally, the composition is spongiform, meaning the volume is more than 50% pure cystic fluid. By contrast, the high-risk malignant profile on the right lacks a clean border. We see spiculated or microlobulated margins cutting unevenly into the surrounding tissue, paired with an entirely solid internal composition. Doppler ultrasound maps the blood supply, providing our next variable. Benign nodules typically exhibit peripheral flow, with vessels wrapping circumferentially around the exterior. Malignant masses demand centralized blood supplies, resulting in vascular lines piercing directly into the core. Finally, the sound waves produce specific visual artifacts. A benign colloid nodule often generates a comet tail artifact, a bright trailing echo caused by sound reverberating off fluid boundaries. On the right, the presence of tiny sand-like microcalcifications is a highly specific hallmark for papillary carcinoma. Macrocalcifications, larger calcium deposits, carry variable risk depending on their context. In a single, isolated nodule, they indicate a higher risk of malignancy. In a patient with a multinodular goiter, they are a low-risk finding. Notably, macrocalcifications are also the most common visual presentation for medullary carcinoma. Physical size does not predict malignancy. Large nodules are frequently benign, and microscopic nodules can be aggressively cancerous. Millimeter count is irrelevant for risk stratification. The decision to target a nodule for biopsy must be driven exclusively by suspicious morphological features. When ultrasound data is insufficient, radiologists layer on functional imaging. Iodine-123 scintigraphy measures the actual physiological activity of the thyroid tissue by mapping where the gland actively absorbs radioactive iodine to synthesize hormones. This functional scan demonstrates a hot nodule. A single hyper-functioning nodule, or toxic adenoma, rapidly absorbs the radiotracer and glows brightly. Because this autonomous nodule is overproducing hormone, the patient's pituitary gland halts stimulation of the remaining normal thyroid, causing the background gland to remain dark and suppressed. Hot nodules are almost entirely benign. A cold nodule exhibits the inverse behavior. It absorbs no tracer and appears as a dark, inactive void within a functioning background gland. While the majority of cold nodules are still benign, roughly 15% are malignant. This specific physiological failure mandates an immediate diagnostic workup. Combining functional radiotracer data with structural ultrasound also allows radiologists to differentiate diffuse inflammatory diseases that affect the entire gland. Graves' disease is an autoimmune condition driving total gland hyperthyroidism. Structurally, ultrasound reveals an enlarged gland with an inferno-hot Doppler signal, reflecting massively increased blood flow. Functionally, an I-123 scan confirms uniformly high radiotracer uptake across both lobes. De Courvaine's thyroiditis presents differently. It is a painful post-viral condition where the inflamed gland spills its stored hormone into the bloodstream. Because the gland is injured, it temporarily stops producing new hormone, resulting in drastically decreased radiotracer uptake during the acute phase. This MRI cross-section shows Radiol's thyroiditis, an IgG4-related disease. The normal thyroid parenchyma has been entirely replaced by a dark, fibrous mass. This dense tissue diffusely enlarges the gland, showing decreased vascularity and severely decreased functional uptake, while physically compressing the adjacent trachea and esophagus. Patients with these diffuse diseases often present with identical, overlapping symptoms of hyperthyroidism. Only the combination of structural, vascularity, or fibrous destruction with radioactive uptake behavior correctly categorizes the pathology. If a nodule passes through the diagnostic algorithm and is confirmed malignant, it generally falls into one of 4 primary thyroid carcinoma subtypes. This matrix categorizes their distinct behaviors. Papillary carcinoma, in the top left, is the most common. It spreads primarily via the lymphatic system. Crucially, papillary cells retain the physiological ability to absorb radioactive iodine-131, allowing clinicians to selectively irradiate and destroy metastatic clusters. When papillary carcinoma reaches the lymph nodes, it produces a specific structural signature. Involved nodes, particularly the Delphian node, at level 6 of the neck, appear hyperechoic on ultrasound and distinctly bright on T1-weighted MRI. There is a critical trap regarding papillary metastases in the lungs. These metastatic deposits can be completely occult, rendering them invisible on standard cross-sectional CT imaging. Detecting them requires whole-body functional scintigraphy. Follicular carcinoma, the second most common subtype, prefers hematogenous spread, traveling through the bloodstream to establish metastases in the bones, lungs, and liver. Like papillary carcinoma, it responds well to targeted I-131 therapy. Medullary carcinoma is associated with the genetic MEN2A and 2B syndromes. It tends to aggressively invade local structures and spread through both lymphatic and hematogenous routes. Because it originates from parafollicular C cells rather than thyroid hormone-producing cells, it cannot absorb iodine-131. Anaplastic carcinoma is rare, typically affecting the elderly or those with prior radiation exposure. It is defined by rapid, chaotic growth, lymphatic spread, and a universally poor prognosis. Like medullary carcinoma, it is completely non-responsive to I-131 therapy. Determining the exact carcinoma subtype dictates the patient's entire systemic management. It establishes the metastatic pathways clinicians must monitor and definitively answers whether radioactive iodine is a viable treatment. Posterior to the thyroid sit 4 parathyroid glands, which regulate calcium levels. Despite their proximity, they have separate embryological origins. The superior 2 glands originate from the 4th branchial pouch, while the inferior 2 originate from the 3rd branchial pouch. This diagram tracks their migration. Because the 3rd branchial pouch structure must travel all the way from the jawline down to the lower neck, the inferior parathyroid glands have a drastically longer developmental journey. This physical distance explains why the inferior glands are far more likely to end up in ectopic locations. When patients present with hyperparathyroidism, a single parathyroid adenoma is the culprit in 90% of cases. Finding that exact adenoma requires applying our same principles of structural and functional imaging. A 4D CT scan maps the structural vascularity. Radiologists track contrast media over time, isolating the adenoma by its distinct kinetic signature, an early, rapid wash-in of contrast followed by a rapid, delayed washout. Functionally, clinicians use dual-phase sestamibi nuclear imaging. This specific radiotracer concentrates in areas of high mitochondrial density and sustained blood flow, definitively isolating the hyperactive parathyroid tissue from the surrounding neck anatomy. Navigating the dense pathology of the anterior neck relies entirely on disciplined risk stratification. By rigidly overlaying morphological data from ultrasound and CT with the physiological realities of nuclear medicine, we can reliably filter out the benign noise and locate the genuine oncologic threats.